Hello, everyone. Welcome to our Diabetes Back to School and Family live stream today. Thank you so much for joining us. I'm Kayla Bowen, Digital Marketing Specialist for Byram Healthcare, and today I'm joined by experts Anna Sabino and Dana Roseman to discuss managing diabetes as we head back to school. Byram Healthcare has been a national leader in patient direct medical supply delivery for over 50 years. We've been rated the best overall diabetic supply company by Verywell Health for 4 years in a row, with an A+ rating with the Better Business Bureau. And we're your one-stop shop for diabetes management supplies. At Byram, we know that life takes care, and today's conversation is one way we are fulfilling that purpose. Before we begin, please note that nothing stated today is intended to be a substitute for professional medical advice, diagnosis, or treatment. Our discussion is for informational purposes only. Always seek the advice of your physician or other qualified healthcare provider with any questions you may have about a medical condition or treatment. Never disregard professional medical advice or delay in seeking treatment because of something discussed here today. So thank you, Anna and Dana, so much for joining us today. So let's begin with some introductions. Dana, would you like to introduce yourself?
Yeah, absolutely. I am the Director of Technology and Applied Research for Integrated Diabetes Services. I'm a certified diabetes care and education specialist and a registered dietitian. I work quite a bit with our transitioning pediatric to teenagers and then moving on to young adults in terms of helping foster some independence with young adults and their families. And as a registered dietitian, I work a lot with nutrition and medical nutrition therapy.
Great. Thank you so much, Dana. And then Anna?
Hi, my name is Anna Sabino. I am one of our emotional health counselors, social workers, also at Integrated Diabetes Services. I'm also a certified diabetes care and education specialist. And similar to Dana, I specialize in working on the sort of holistic family approach to managing diabetes. I work pretty closely with a lot of parents, kiddos, young adults, and also transitioning into that independence piece as they move through into adulthood.
Great. Thank you both again so much for joining us today. So today we're going to talk about back to school and family support when it comes to going back to school. Before we started the live stream, we were talking briefly about how a lot of folks are reaching out to you about back to school now. Let's talk about managing diabetes at school and what to share with your child's school regarding type 1 or type 2, whoever wants to begin with that. What are the main things to keep in mind?
Well, maybe let's talk about the definition between type 1 and type 2 to start. So, type 1 diabetes is an autoimmune disorder where the individual stops producing a life sustaining hormone called insulin. And so, without insulin, that child needs external insulin sources. Very often, it's through the form of an insulin pump. Very often, it could be through injection therapy, but that is an important life sustaining therapy for that child. For type 2 diabetes, we have a lot more wide range approaches to therapy. Could be diet related, could be some oral medication related, could be lifestyle related. So they both have the word diabetes in it, but for pediatrics can be approached in a very, very different way in terms of therapy.
Okay. Anna, do you have anything to add on that?
Honestly, not in terms of the definition. I think the most important part and something to keep in mind is that especially when we're talking about school nurses, the way diabetes is managed is very individualized and very customized to their specific doses, where they're at in their growth curve, how long they've had diabetes. It's an autoimmune disease, so there are thousands of like variables that we often don't see when a child comes into school that may be impacting a rise or a fall in their blood sugar level that has nothing to do with a miscalculated insulin dose a few hours prior. So I think that is one of the most critical things to share with school staff in general, is that not one person's diabetes is the same. I think sometimes school nurses especially just assume, or sometimes can, oh, well, last year this person only came to the nurse X, Y, and Z. That's only one person. So really just taking a moment to share what works for your family at home and how to transition that into the school environment is really key.
And I would also add on that just the way that the family feels about diabetes management, how open they are to talking about diabetes management with family and friends. And it's so personal, like Anna said, but that is such a holistic approach. People take such a holistic approach to their diabetes management, especially with their children, and their comfort level is at different places. Even if they've been diagnosed for, 4 years, they may really feel like they're still struggling, and it's not such a comfortable topic for them.
Yeah, absolutely.
Right. So when it comes to developing a diabetes medical management plan for your child, how would one go about that? And how might that be different between an elementary age child versus middle school, high school?
Again, the first step, well, first of all, I'm going to back up for a second, because when we're talking about the medical management plan, that is something that all, endocrinology offices or the clinics are required to provide to the school if requested. So these are the doctor's orders, the symptoms, the, basal rates and bolus calculations that will be used during the school day, if necessary, that are provided and signed by the doctor in conjunction and put together with the parent and the family. Oftentimes, institutions or pediatric, offices will have a specific school form that they use. Some don't, but they work in conjunction from the medical provider. But this is essentially a prescription of doses that are either set in the pump or based on carbohydrate intake that the school is required to follow, because they're essentially doctor's orders. It's similar to like, oh, give an inhaler if child exhibits X, Y, and Z. Well, this is the same thing, only we're talking about a child with diabetes. There's just a few more variables that go into play for their doses. So that's the first step. The other piece is what we call a 504 plan, which is the legal accommodations that sort of often accompany the diabetes medical management plan. And based on where you are in your duration of diabetes or your ability to self-manage, it's gonna change. An elementary school student may not understand what it feels like to be low and require some assistance from the nurse, whereas a high school student may be very much able to give himself his own insulin and doesn't need as much oversight from a school nurse or other staff personnel. So it's really important to get to know the family, like Dana mentioned, to understand where they are at. I've seen some 14-year-olds who completely self-manage. And then I've seen some 14-year-olds who still need a lot of oversight in terms of making sure that, they get their doses right. And some parents are not comfortable with a child, overseeing their care. And some schools have a harder time accepting that they may not need to see every kid with type 1, based on where they're at with their diabetes and their ability to change a pump site and this, that, and the other thing. So it really depends on so many factors. But
and
for
the teachers themselves too, right?
Teacher,
I mean, the teachers and the shadow staff, if there is, and then the school classroom. I mean, there's a lot that goes into that plan.
Oh yeah. 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 And the biggest takeaway is like the further you can reach out and start that process of getting to know the school and sharing that information with them, I think the easier the transition usually is. Sometimes that's hard in the summer months, but it's usually easier the earlier you can get the process going.
Right. And, public school versus private school, that is a whole different set of circumstances as well. Public schools, quite frankly, can be a little bit more accommodating. They have the legal requirement to be accommodating. And private schools sometimes have very strict policies on teacher or administration staff even touching the buttons of a child's insulin pump, and that makes it very difficult for parents, and the burden is really put on parents to do quite a bit as well. So it really depends on the school and the district policies.
Yeah. Yep.
So what are the top accommodations in a 504 plan?
Yeah. And just to back up a second too, the 504 plan is stemmed from Section 504 from the Americans with Disabilities Act. And really the point of the 504, which is sort of this like blanket document, is so the child gets equal access to education, regardless of the fact that they have type 1 diabetes. So it's really about equal access. And to Dana's point, if a school or an institution receives any type of federal funding, they're required to allow students to have a 504 plan if they have a type 1 diagnosis. So just wanted to kind of like set that playing field.
It would be the same if they had a learning difference.
Exactly.
It's the same plan.
IEP, and it's all about access. To that point, and I don't know if Dana would agree with me, I think if you're thinking about putting together a 504 plan or getting ready for a meeting, access is, I would say, one of the top accommodations that I would include. Unlimited access to all diabetes related supplies. And that includes a cell phone for most kiddos who are likely using a continuous glucose monitor to track their blood sugars trends. And that could also mean access to the bathroom, unlimited access to snacks, water bottle. My daughter is 7 and she has a little girl in her class, and there's like a drawstring bag that has all of her stuff in it. And her little phone just stays on the desk with the teacher, and people kind of just follow along. She knows when she's
and it is right.
But it really depends.
It depends. And the teachers, really have strong opinions. If everybody is supposed to leave their backpack outside of the classroom, but this one child is allowed to have a phone sitting on his desk or the backpack right there, I mean, that needs to be a conversation also with the classroom and the students. And continuous glucose monitors really are standard of care now, and they do come with some alarms that can be disruptive. And so working with the teacher so that they don't feel it's a burden from the get-go, I think is so important. And there's actually some, especially for the littles, there are some, other things to add on to your continuous glucose monitor. There's that glucose, which you could have in the classroom, and it has different colors based on what the child's blood sugar is. It's a little bit less, it doesn't have alarms, and it's a little bit less judgmental in terms of class. So there's so many things that parents and families,
which will actually display the blood sugar. I know some parents like keep one in the nurse's office or one in the classroom. Again, it's going to depend on the child's ability to self-manage and sort of be in tune based on just their personality sometimes. And it's going to depend on the teacher comfort level. This 7-year-old in my daughter's school, very small school, literally across the hall from the nurse's office. So she can honestly hear that alarm and be like, oh, let me go check on kiddo and take care of it. But it's more about the approach in terms of the management with the school than I think the specific actual accommodations in terms of getting what you want. But I think the number one is really just the unlimited access to make sure that kids with diabetes have what they need to be successful in school. And that might mean snacks in the classroom, bathroom breaks, all of those things.
But I would also say for the older kids, thinking about testing, what if you
Absolutely.
come to school that day and you have a insulin pump that fails and you hadn't received insulin for a significant amount of time, your blood sugar is high, you don't feel well, nobody can think, in a sharp way for a math test, for example,
Yeah,
if that happens. And so having that ability to move assignments or have extended time, which every kid who has diabetes, really even thinking forward for college college board
absolutely.
exams. I
Yeah.
mean, we want to set that up early so
Yes.
that kids know that's available to them. They don't have the anxiety of walking into a test when they're just not physically capable of thinking the way that they can and
Yeah,
should.
absolutely. I think, the ability to either extend test taking time, or the other one I often see is unlimited makeup time, or
Hmm.
unlimited absences, or to not be penalized for missing school due to diabetes related illness. A lot of times we have the flu and it takes us a couple extra days to recover, or
Right.
have to be hospitalized, God forbid, because of a pump failure. That should not be, docked in terms of tardiness or whatnot. The last thing I'll say too, especially as you get into those older grades, is this includes all school sponsored events and activities. So like senior prom and field trips and sports. I had one girl come to me saying, I missed tryouts for 3 days in a row because I was low and they're not letting me on the volleyball team. And I'm like, well, A, that's illegal. And you have a 504
Right.
plan. Let's figure
Right.
this out. So a lot of it is just constant re-education and reminding of that, inclusivity that is illegal to not allow.
And I would also think through, I think, Anna, you and I spoke about this offline a couple of days
Mm,
ago, that, treating a low blood sugar. So when someone has a low blood sugar, a hypoglycemic event, they need rapid acting sugar, and they need that rapid acting sugar now. And walking down to the nurse's
mhm.
office or having to leave recess in a large field and walk all the way to the nurse's office for that treatment is really dangerous and something that ought to be put into that
Mhm.
504 plan so that kids can get that
Yeah,
necessary treatment immediately. I see
yeah,
that as a left off item quite frequently for 504 plans. And then the other thing I see left off quite often is not just extended time, but suspended time, meaning that if
yeah,
there's an issue with a pump and a child needs to take action right now during their English essay exam, that they can do that, but it's not taking part of their extended
yeah.
time that they may otherwise need.
Okay. Yeah, I didn't think about that. Most of what I've seen, it's like, okay, you have the ability to stop and start and you can finish whenever you want. But I think that's a good point. And the other benefit of having a 504 plan in place is that it carries with you, assuming you
Hmm.
don't change schools. Once you kind of create this process and start it, it carries with you through the 12th grade. And I know even,
It carries with you to college. Yeah.
yeah, yeah. I mean, there are no technically 504 plans in college, but it's a lot easier to just up and transfer some
Right.
of these similar type life skills in terms of advocating what you need as a college
Right.
student if you're starting this process in high school. So it's like, having, health insurance. You hope like you don't never need it a lot of the
Right.
times, but it's always helpful to have in place when something does go sideways a little bit.
So, when it comes to a parent of a newly diagnosed child, in developing a 504 plan, if someone must feel, overwhelmed in beginning
Mm.
that process, what are some resources that they could go to for that?
Anna.
Yeah. So, oh, me? Like, yes, you can come to me.
No. I mean, you are the resource. Yeah.
Right, right. So, I do a lot of workshops personally on how to develop a 504, how to approach the school, because I think so much of parents are nervous about sending their baby off to school. You're just bringing them home from a hospital stay, likely. And essentially, it's like bringing home a newborn again. And now you have to put them back out in the wild, and you're so flooded with information. So in terms of resource, from a concrete perspective, the American Diabetes Association has a lot of sample templates in terms of how to get started with a 504 plan and the process. My first piece of advice is always just give the school a call. Calling them is better than email. Email, to me, when you're dealing with something like this, just doesn't exude a sense of urgency, and like you want to get a meeting on the books as soon as possible. Most of the time, schools have gone through this type of either IEP or 504 plan process before, so they should have a process. But the ADA, and there are honestly like loads of other like diabetes organizations out there that have sample templates and top 5 to include. Personally, I do, as a part of my private practice and with integrated, is just back to school workshops. Right now, we're very heavy on free webinars in terms of helping parents navigate what to include, what to say, what not to say. I also have a free resource on my website. I call it the Teacher Tear Off, but it's like a Mad Lib style one pager where the kiddo can actually fill out their individualized signs and symptoms, because I think so much is the parent doing the talking, especially with the little ones. And a lot of the times the teachers in the classroom don't necessarily see this kind of big, bulky plan that may be signed by the principal or the school nurse. But the gym teacher, the soccer coach, like they need to know the basics. So it's an opportunity to empower the child to sort of advocate on their own individualized needs. Dana, any other resources that you're?
Yeah, I mean, I think hopefully the endocrinology office or the children's hospital in the local area not only has a plan, but they know the districts that are in that area and can speak to maybe the limitations or maybe the resources locally. I do think that, there are so many aspects of diabetes that is blood sugars that are impacted by, activity, food, emotions, stress, drama with a friend group, all of that impacts blood sugars. And so when we're talking about a 504 plan, we're really talking about a very wide action plan, and that the teacher can say, okay, if this is happening, it's almost like choose your own adventure, kind of follow the script of if this happens, go here, if this happens, go there. But newly diagnosed families don't have that, unfortunately. And so that's what makes it quite overwhelming. I think having some really open communication with teachers, but some teachers have 35 kids in the classroom, and that's just not something that they can do. And so it really, I know we keep saying it, but it is so personalized and different at every age group. I mean, a kindergarten action plan is going to be very, very different from a middle schooler. And the middle schooler really, I think Anna and I both agree that diabetes management ought to be managed enough by that middle schooler that they do have some independence. They are able to treat their low blood sugars. They're able to have access to their technology devices to give more insulin. That's our goal. Our goal is by 12 years old that a child may not be able to do everything diabetes related, but they certainly could, if we had an insulin pump failure, they could change that out. If they had a continuous glucose monitor that fell off during PE, they could, go ahead and put that back on. So it's certainly an evolution over the entire school.
Yeah. And I think one of the hardest challenges is that a lot of the times we see parents like afraid to let that child go. I see most of the time, if kids are diagnosed 12, 13 above, they are sort of self-managing right out of the gate.
Absolutely. Yeah.
And I think what we see so often is that these kids are diagnosed at 2, 3, 4, 5, and that's where the harder transitions come in. Sure. Because these parents have been like doing it for so long. Right. So it's obviously habitual for them and it's harder to let go. But when it comes to self-management, I think the best approach is just like, hi, what works for you in your school? we were just diagnosed with diabetes. We're really overwhelmed. Can we set up a meeting? And I think it's a call first. There's also a ton of, I say with caution, like local and national, like Facebook groups and apps and whatnot. But if you're newly diagnosed, like it's going to be a rocky road for
It is.
those like first few weeks, few months. I know a lot of parents try to like take that week off if they can, that first week, just to kind of like be available. Okay, well, what's happening? What's this process? Because it can be very overwhelming.
Right. I mean, a newly diagnosed family has a crash course in a master's level of nutrition, biochemistry, biology, technology. It's just a lot.
Right.
And so, hopefully schools can be a support for those families and not a burden.
So, on the topic of very little children being diagnosed with diabetes, and then how can parents begin to foster independence as they get older? Like, what are good ways to begin doing that?
There's actually age appropriate guidance for that, in the same way that you would have guidance when you're starting solids with a toddler or an infant. Basically, you start with rice and then you move on. So diabetes management can be very, very similar in terms of guidance. Depends on the child's fine motor skills, how they're able to manage a lot of the technology, because unfortunately, diabetes management has very much become technology management as well. But I think fostering that independence with young children gives them ownerships of their disease, and they don't see it as a burden, just the way that I don't see tying my shoe as a burden. That's just what I do. And then I think eventually that child sees changing their devices as a similar action.
Yeah.
And then one thing, and I know Anna might agree and can definitely speak more on this too, is that the parents' approach to the diabetes management, and parents feel guilty. They feel so sad for their child, and of course, completely understandable, but letting that child know that this is kind of just what they do. There's not an association of emotion and burden. Yes, the family does have that sadness and grief, but the everyday, doesn't have to have that so much.
Yeah. I think the only thing I would add to that too is that, to your point, Dana, there may be some limitations, obviously dependent on like gross motor skills, or if the child has ADHD, like pick one thing to work on first, whether it's picking a finger or, it's not going to be an overnight process. I mean, I think we want to start the transition to independence, meaning you're living on your own completely, whether it's college or work or an apartment, like right around 11 or 12. And that may mean like spending some time in a doctor's appointment for even 10, 15 minutes without mom or dad present. It may mean like mom or dad not following everyone's blood sugar, or allowing a child to have a sleepover. There's obviously developmental things that are age appropriate. Maybe you wouldn't let an 8-year-old just like give themselves a shot without checking the dose with a mom. There is this sort of checklist where child does it with parent oversight, then child does it without mom checking, but at home. Then you move towards, it's like walking, first you got to roll over, then you got to crawl, then you got to stand up, and then you can go. It's sort of the same thing. It's not like, unless you're old enough, okay, we're changing our site all at once and we're good at it. So I
like the walking analogy, Anna, because what do you have to do when you start walking? You got a lot of bruises and you got a lot of falls.
Yep.
And so none of this comes without any hiccups, and some big hiccups. And I think that failure, not dangerous failure, but some struggles along the way will really lead
opportunities. And I think the longer you wait to practice some of these sort of like growth opportunities in terms of letting them go, is only going to potentially cause harm in a psychosocial ability to navigate the, diabetes as an adult in the long run. I see that a lot with some of my clients now, where like they look back and they're just like, wow, I wish I was more educated. I wish I had X, Y, and Z. So, and I also think, to your point, Dana, like making sure that the parents of these newly diagnosed kids, whether you're 2 or 12, are getting their own support
Right.
in
Absolutely.
separation from the child's diagnosis, because so much of it is what this parent is taking on. And if the parent, we all know, if the parent can't
Right.
regulate their own emotions, kids are going to pick up on it all. Yeah.
Absolutely.
So, what is the role of family in emotional support and diabetes management, like across the board? How can parents, grandparents, siblings, like do their best to support a child with diabetes?
I might say it depends on where that child is in their acceptance of the diagnosis, how long they've had it. Kids that are diagnosed at 2 don't remember a time where they don't have diabetes. They
Yeah.
don't remember a time that this is just like brushing their teeth to them, right? They're
Yeah.
just putting on their infusion set, they're putting on their insulin pump.
Today's a
Um,
safe
you know,
day.
Exactly. And then there's some kids or some adolescents that are diagnosed at 16 and they are owning it from day one. They feel
Yeah.
like they are mature enough to take care of this chronic condition. I know Anna could speak a little bit more about the emotional support that families, and it depends on the family dynamic also.
Right.
If there is a type A family member who feels like they, ought to be able to have perfect blood sugars, well, that type A person is really going to set back that child, because the truth is, people living with type 1 diabetes cannot have blood sugars that match someone who is producing, natural insulin.
And that is a hard piece of information for parents to swallow, is
Right.
accepting the fact that as hard as they work and hard as the child works, their life is forever changed.
Right. Expectations, right? In terms of what
It's
is
level set
realistic expectations.
and is the parent grieving or is the child grieving? And that's
Mhm.
where, having, whether it's a therapist or an educator or somebody who's able to help process that can really help the parent-child dyad relationship
Absolutely.
grow and not hinder. But in terms of navigating some of that support, I mean, community is huge. There are so many local
Without comparison, right?
without comparison. Yeah. I
Yeah.
mean, like for kids and young adults, especially, it can be very isolating when you're first diagnosed, very much alone. There's a lot of inner monologue, a lot of guilt, a lot of shame that goes in that. So,
Mhm.
With caution, summer camps and are amazing opportunities for kids and a little break for parents, local groups. I actually think there are so many, depending on where you are. Everyone is willing to share their diagnosis story. Like
Absolutely.
after you have a baby, it's just like that. Everybody wants to share their diagnosis story. It makes them feel included. But there are conferences and camps and like Breakthrough T1D, formerly JDRF, American Diabetes Association. There's lots of local meetup opportunities for both kids and parents to.
And Anna, don't you also have a supporting caregivers?
Yeah, in the fall, I do a course called Coping for Caregivers, and it's Zoom. It's like a 4-week program where parents really just kind of get to vent, talk about some communication strategies, and talk about like acceptance and a lot of that grief process in a really small group, intimate setting. The other thing too that I always like share with parents is, the child is always the team captain of their ship. And you may think you're on the same ship as them, but you're not. You're kind of in that passenger seat, and learning to sort of just like accept where your role is very hard, with the roles kind of constantly shifting and changing as that child is moving towards independence. So really taking a time to check in with yourself as a parent is huge, so what your role is, and realize, am I overstepping here? Am I crossing the boundary line? Maybe this kid
And
really
it's hard
is,
to do.
And it's really hard
Yeah.
to do.
I
It's
mean,
really hard
as a mom watching children become independent, putting a child in a car for the first time and letting them drive down the street to go meet up with friends is maybe the most terrifying thing. Second, to letting your child take over a chronic condition that is very complicated. And so, like Anna said, making it kind of in small steps, I think is really helpful and healthy for parents, with the ultimate goal that their childhood and then adolescent is a dress rehearsal for
Mm,
launching that independent child towards college and young adulthood.
yeah. And I think too, just because a child may turn 18, it doesn't mean that they're kind of lost and gone
Right.
forever.
Right.
I
Right.
know a lot of college students, young adults either still live at home, and a lot of, pediatric hospitals, diabetes is so complex. It's one less thing to have to transition right away.
Right. And they will see kids through the end of their college. Yeah.
Yeah. Sometimes through 25, 26.
Right.
So knowing that information can be like very empowering. So you're not just like transitioning all at once.
But I would also say a lot of kids, as they're becoming more independent, they haven't gotten the basic training of diabetes that their parents did at original diagnosis, because the parents did. The parents got a lot of information. They read all the books. They were on all of the, Facebook groups. And then the child is 17, 18. They didn't get sick day management guidance. They didn't get, emergency, glucagon injection education, because the parents did. So I always try to remind families to, even though you're already at the advanced stage of the book, you go back to chapter 1 and just refresh that with your child, because at every stage of their development, they may have forgotten some of those basics that parents they take for granted.
Absolutely. And it's a learning process. Again, it's just like ask questions to your teen, know that they're there, and they're also a kid and a teenager first before they have diabetes, and they were a kid before that diagnosis. So definitely keep that in mind as you've got nerves and all the feels as you're sort of navigating the next phase.
Right.
We've got a question in the chat from Robert asking, what should a child tell their friends about diabetes? How should it be explained? And what if a child is embarrassed?
That's a great question. And I do think that Anna and I both hear from families and children alike. It really depends on the age of the child. Hopefully the younger children, I don't think have as much stigma as maybe preteen and teens. I do think that sometimes that acceptance and the way to talk about diabetes starts in the home, and, eliminating any burden or stigma that way. That being said, I have type 1 diabetes. I don't personally wear a lot of my devices externally. It's what I choose to do, because diabetes is not everything about me, right? I want someone to know me as someone who just everything about me outside of my diabetes. But I do think that for children, talking about diabetes can be a safety issue. In other words, if you go to a friend's house and nobody in that house knows that the child has diabetes, that obviously can be dangerous. So perhaps, and Anna can speak about this a little bit more, perhaps coming from what makes sense for each situation, and then finding your people, your close friends, and starting the conversation, letting them watch you do an infusion set change or a pump change, letting them watch you maybe weigh your food in the kitchen and figure out the carb counting. I often find that kids can be real. They love to have their other friends' blood sugars and following them along, and they love to support them. I have yet to see a best friend who wasn't excited to be honored enough to have Dexcom Follow on their phone, and it's really another bonding aspect.
Yeah, I mean, I think you hit the nail on the head when it comes down to, where are they at in their diabetes?
Exactly.
If it's a 5, 6, 7, 8-year-old, bring a book into the classroom. This is the new me, and share I want you to ask me questions about it. Even I also live with type 1. I wish more of my like adult friends asked me more about it, because even as an adult, it can be very lonely and isolating. And like, I'm showing up to the gym already like strategizing in my head how to figure out bolus calculations with rate of exertion and what I'm planning to do. And nobody knows how much of mental effort it took to get there. So figure out at home, like, how do you want to receive that support?
Right.
What type of support are you looking for? And it's going to take a long time, especially for, young girls, even to understand and know that they won't ever fully understand the exact full picture that you're experiencing. But the more you kind of like let it down and sort of be open to willing to share, the more likely it will be brought up naturally. And if you hide it, I mean, sure, as an adult, maybe you're not going to wear your devices on your sleeve, literally. But it's not like you're going to deny it if someone asks about it. So it's, are you closed off? Are you timid? Then you have to be comfortable sharing and show that you are, with body language and things like that. But agree, like, even when you go off to college, like, someone has to know. It's
and that's a safety issue, the same way that you're spending the night out at a friend's house. Yeah, that's a safety issue.
Yeah.
Robert followed up, is it okay for a child to show their insulin pump to explain how it's managed?
Oh my God. Absolutely. Yeah, absolutely. And honestly, he'll be like, or she'll be the coolest kid for the day, right? It's like the best show and tell ever.
Yeah. Yeah. Love that.
Awesome. So what are some tips for school staff or school nurses that you would give?
I mean, I at the end of the day, I think it would just be, make sure that you meet the child where they're at. Again, reiterating that every single person living with diabetes might manage it differently. There are 3-4 different pumps on the market, and maybe you're only familiar with one. There are multiple meters on the market. I mean, there's so many different pieces of technology, and to try to kind of go into the school year with a very, very open mind for learning what is going to work with that individual child. Meet the family where they are. They are coming in probably scared to death. Maybe not some of the older grades, but blank slate across the board in terms of being willing to learn and figure out how is this child going to best thrive in a school setting while also living with type 1.
And I would also say the technology is also not one size fits all. Certain children are going to have higher blood sugar targets. Certain children are going to be able to tolerate a lower blood sugar target. And I would say the treatment of low blood sugars is wildly different as well. Kiddos that are on automated insulin delivery systems need a fraction of blood sugar treatments or low blood sugar treatments than kids that are maybe on multiple daily injections. And so I do think, to your point, like, nurses are amazing, but they have so many diagnoses and conditions that they're managing. And so it's easy to kind of get in, oh, little Susie last year did this. She had a juice box when she was low. Oh, but Johnny here, he's on an automated insulin delivery system. He needs just a single glucose tablet.
Yeah, exactly.
Right.
And as you are hearing from a lot of parents who are gearing up for the school year to start back up, what are some of the common questions or concerns that are coming up in these discussions?
I mean, I think what Anna said earlier is access.
Yeah.
Where am I going to put my supplies?
Where am I going to put the supplies is huge. I mean, these kids, when you travel with type 1, even like leaving the house, sometimes it's an extra backpack. You've got like an extra site. You've got a vial of insulin, likely. You've got low treatment, which may be like some gummies or a juice box. So there's like some stuff that come with having type 1. Where's the best place to keep it? Are you going to keep it in all the different classrooms? But I also think too, who is responsible for responding if they're on a CGM, who is responsible for quickly responding to a CGM? Because I would say probably close to 90% of kiddos are using a continuous glucose monitor within a month of diagnosis now, which is phenomenal because it's less finger pricking, less blood, whatnot. But that also means we need the reaction time and the ability to respond is quicker. So if there's a child that can't or process their lows, it's really taking a deep dive into understanding what are people most comfortable with. And again, some people's threshold for a low blood sugar might be 80, some might be 100, some might be 55, depending on the system that they're using. The other one too is that a lot of parents are used to someone having access to like follow their blood sugars on a phone. So is the school going to provide the device like a phone or an iPad or another tablet? Like, who is responsible for responding to these high and low alerts? And at what point does a parent get notified? So there's just like, there's the technology is wonderful, but because we have access to all this information, it is a little bit more nuanced in terms of setting up a plan. So I would say that is probably the biggest discussion and complaint. Oh, my school nurse doesn't get it. Oh, they're refusing to follow on the CGM. Oh, like they won't give us an iPad, or I have some parents who are saying in high school, like they're over following the child and not letting them get on
I have seen that too.
At a certain, like they're overprotective. So again, every family and child is different. But the biggest concern I would see right now is just around the remote following and whose job is it to intervene at what point.
And then I would say another kind of underneath that, and the next barrier is pre-bolusing for lunch. So insulin does not work right away. We call it fast-acting insulin, but we all know it is not. And
especially if the blood sugar is not in range, and then like you're going into a meal with a blood sugar that really needs an additional maybe 2 or 3 units to bring it
and some extra time to bring it down. And so I do see that as a big barrier burden of, depending on how the child is allowed to take their insulin, do they have to go to the nurse's office for lunch? And figuring out that pre-bolus for lunch can be really one of the most difficult things to accomplish in terms of the school day and keeping blood sugars within range. The other thing, and this is kind of it seems simple, but for some reason it's a barrier, especially for lower school, middle school, or elementary school, and then middle school. You know, where is physical activity taking place during the day, and getting that schedule ahead of time. So I've seen PE classes where the kids are sitting down and learning about the digestive system, and they don't need adjustments to their insulin for sitting more. But then the next day they're having basketball practice during PE. And so I always say, if we can figure out when meal times are or snacks, and if we can figure out where activity is, we can plan accordingly. And, you know, so sometimes I say, get that PE teacher involved in these communications and lesson plans. Find out what the lesson plan is on a regular basis. Even if it's a week or a day ahead of time, parents can then get that information.
Yeah. Yeah. I would say too, like, final words, if we're at that point, be patient, like be patient with the start of school. I mean, like it is a 4 to 6 week transition process. I know I always say this, you know, you parents hear this all the time, like a week or two before school starts is not when you want to start a new device. Is not when you want to be changing doses, is not, you know, like you want to have like a reliable site in your system when you go to school. Your devices are charged. You know, sleep, even practicing eating at the time that you are,
and the meal,
lunch, if you can, right? You know, we all say we're going to put our kids to bed earlier the week before school starts. Does it happen? No, but the teachers feel it. These kids are coming in exhausted, overstimulated on that first week, which is why it takes so long for this adjustment to happen. Their sleep schedules are all off. Their activity schedules are all off. And it can still be hot out. But cut everybody some slack. It's a huge transition for everyone. And hopefully that means everyone will have a great year.
Right.
Yeah, so you beat me to it, Anna. I was gonna prompt some final thoughts. So, Dana, is there anything that you would love to leave our viewers with as we close out the conversation, as people gear up for the school year to start?
I would actually, having your child who has type 1 or type 2 and wearing that continuous glucose monitor, which really, like Anna said, I mean, 90, if not more % of those kids are, you do have an insight into how they're feeling, how they're coping, how they're going into their school day. Use those patterns and use that knowledge to help support your child. What I mean by this in actuality is you might see a spike every single day at math class. You might find that that child's anxiety or their stress about going into some subject is really a pattern, or they're having, some sort of activity and you're seeing a change in their blood sugar that way. That can be a real gift in terms of knowing what's going on in your child's mind, more so than if they didn't have that CGM on. And so I do see that as maybe a silver lining that some parents overlook.
Yeah, that's a great point. You know your kid better than anyone. Be their best advocate when they can't do it.
Absolutely.
We did receive another question in the chat. So Mary asks, is there a one-page reference document that patients can share with teachers to educate on what to look for, risks, and when to send the child to a nurse?
Yeah.
I'm positive that Anna has it, but there are
Right
for
here.
sure.
I created one actually because so many parents were telling me that, like, oftentimes we suggest that a child attend the meetings. Really, like a child needs a parent there to discuss adult things on their behalf, but really it's about the kid. So having the kid have as much say, and when they're low, when they're high, sometimes a kid's symptoms may be like, my belly feels funky or I feel off. And it may not be the nurse's interpretation of like sweaty, shaky, whatever. Like the kid may have their own way of sharing that. And that's really important for teachers to know. So you can, and it has like the name of the child, the mom's cell phone or dad's cell phone on here. When it goes low, I need this. When it goes high, I need this. And you can download it for free on my website at findingsmilescoaching.com.
Awesome. Yeah, I was going to ask how, if someone wanted to get in touch with either of you or access any of your resources, how would they go about doing that? So
I'm also going to put in a plug, the Integrated Diabetes Services team. We are doing, we run a caregiver kind of support Zoom program. Our next one is on September 10th, which will be all about sort of the approaches and attitudes with your school, sort of like building a foundation to set your school up for success. And that is free. And you can find all that information right on the integrateddiabetes.com website. Dana,
that has a lot of resources. My contact information is on the integrateddiabetes.com website. And I know Anna's is as well. And there is just a lot of information there to sift through.
Amazing. And you said that you can access that one pager at findingsmilescoaching.com.
Yep.
That's a really helpful resource. So thank you both so much for joining us today. We got a lot of feedback in the chat about how informative and what great advice you provided. So thank you. It's a pleasure to speak with you. And before we close out, I just need to note again that nothing stated today is intended to be a substitute for professional medical advice, diagnosis, or treatment. Our discussion is for informational purposes only. Always seek the advice of your physician or other qualified healthcare provider with any questions you may have about a medical condition or treatment. Never disregard professional medical advice or delay in seeking treatment because of something discussed here today. So thank you everyone for joining today, and we will see you back on a live stream next month. We'll be talking about self-care and self-improvement. So stay tuned for details about when that will be. Anna, Dana, have a great weekend, and thanks again.
Thank you.